Welcome to the Deep Dive. We're tackling some familiar territory today, but with a fresh perspective. Bacterial eye infections. We're using the World Health Organization's AWARE Access, Watch, Reserve Antibiotic Book. You probably know pretty well.
Oh, absolutely. AWARE, great resource.
Yeah.
Always good to revisit those guidelines, especially with antibiotic stewardship being so important these days.
Yeah, definitely. It's a balancing act for sure.
Yeah.
So ready to dive in and see this common ground in a new light.
Always up for a challenge. Let's do it.
Okay, perfect. Let's start with probably the most frequent visitor to your lab. Conjunctivitis, Chapter 10 in the AWARE book. It defines conjunctivitis as an infection of the conjunctiva, that membrane lining the eyelids and sclera. Pretty basic stuff, but I bet it's more than just a definition for you.
Oh, definitely more than a definition. I see these samples every day, swabs, cultures, the whole works.
Right. So walk us through it from your perspective. What's the clinical presentation that really guides your diagnosis?
Well, patients usually complain about that feeling of having something in their eye. They say it feels like sand. And of course, the eyes are red and watery and itchy.
Classic conjunctivitis symptoms.
Yeah.
But how do you differentiate between the different causes?
Discharge. That's key. Thick and purulent discharge usually means bacteria. But if it's watery, it's probably viral or allergic.
Ah, so that's the first clue. And the AWARE book says most conjunctivitis cases are viral and self-limiting. So when do antibiotics actually come into play?
Well, they're not always needed. But if we suspect bacterial conjunctivitis, antibiotics can shorten the duration of symptoms for the patient.
Makes sense. But as we said, the tricky part is figuring out if it's actually bacterial, right?
Exactly, and that's where the expertise of a medical microbiologist is so important.
Absolutely. Okay, so let's say we've got a confirmed case of bacterial conjunctivitis. What does the AWARE book recommend for treatment?
The book recommends gentamicin or afloxacin eye drops, or tetracycline ointment, all for 5 days.
Okay, so those are the go-to options. Do you see any trends or patterns with those antibiotics in your lab work?
You know, it's interesting. The AWARE recommendations are a great starting point, but we do see some regional differences in antibiotic susceptibility. What works great in one place might not be as effective somewhere else.
So it's not a one-size-fits-all approach.
Exactly, and that's why it's important to consider local data and resistance patterns.
Makes sense. That local expertise is invaluable. Now, let's talk about a specific type of conjunctivitis, neonatal conjunctivitis. The AWARE book specifically addresses gonococcal and chlamydial infections in newborns. Can you break down those infections for us?
Sure. The timing of the presentation is really important here. Gonococcal conjunctivitis, or ophthalmia neonatorum, it usually shows up within the first few days of life. You'll see purulent discharge, eyelid swelling.
So very noticeable and pretty quick.
Yeah, definitely. Chlamydial conjunctivitis is a bit more subtle. It usually appears later, maybe a week or two after birth.
Ah, so that difference in timing is a big clue. And how does that affect the treatment approach?
Well, for gonococcal cases, a single intramuscular dose of ceftriaxone is the standard treatment.
Okay, straightforward enough. What about chlamydia?
Chlamydia is a bit trickier. Topical treatment alone isn't usually enough. The AWARE book recommends oral azithromycin for 3 days.
So you're treating the infection systemically, not just on the surface of the eye. Makes sense. And any advice from the AWARE book on prevention for these infections?
Prophylactic topical treatment for all newborns, erythromycin or tetracycline ointment, applied right after birth.
Simple intervention that could prevent a lot of problems. Great. So we talked about clinical presentation and treatment. Now let's get into the nitty-gritty, pathophysiology. The book talks about exogenous and endogenous transmission. Can you explain that for us?
Think of it this way. Exogenous is like an outside job, right? Touching your eyes with dirty hands. Or if a contact lens scratches your cornea.
Makes sense. So what about endogenous?
Endogenous is like an inside job. The bacteria are already in the bloodstream, maybe from another infection somewhere else in the body, like endocarditis, and they travel to the eye.
Ah, so you might see other signs and symptoms in the patient that point to an underlying issue.
Exactly, and that's where your microbiology knowledge is so crucial. You might be the one to connect the dots between a blood culture and an eye infection.
Love connecting those dots. Okay, now let's zoom out and look at the big picture. Epidemiology of conjunctivitis. It's the most common eye infection, but is it always bacterial?
Not even close. Most cases are actually viral.
Interesting. So not always a reason to jump to antibiotics then.
Exactly. And we can't forget about allergies. Allergies can mimic the symptoms of conjunctivitis. That's why a good history and exam are so important.
So many potential culprits to consider. Speaking of culprits, the AWARE book lists the most likely pathogens for conjunctivitis. Adenovirus is at the top of the list for viral cases. What about bacteria?
Well, it depends on the age of the patient. In kids, it's often Staphylococcus aureus, Streptococcus pneumonia, Haemophilus influenza, Moraxilla catarrhalis. You see a mix.
So it's kind of a free-for-all in kids. What about adults?
In adults, S. aureus is the most common one we see.
Interesting how the microbial landscape changes with age. Now, we can't forget about those two troublemakers, Chlamydia trachomatis and Neisseria gonorrhea. They can cause quite a stir, especially in the context of STIs or neonatal infection.
Oh, for sure. Those are important ones to keep in mind. And while the AWARE book focuses on treating conjunctivitis caused by these guys, remember C. trachomatis can also cause trachoma. That's a chronic inflammatory disease that can lead to blindness.
Yeah, trachoma. Serious stuff. The AWARE book has a whole chapter dedicated to that, right?
That's right. A whole chapter on trachoma. Maybe we can dive into that another time.
Definitely. We'll add that to our list. But for now, let's shift gears to a less common but much more serious eye infection, endophthalmitis.
Oh, yeah. From a nuisance to a potential vision thief, that's a big jump.
Definitely a whole different ballgame. So endophthalmitis is an infection of the intraocular fluids and the retina. What are the signs and symptoms that scream endophthalmitis?
It's different from conjunctivitis. It's not itchy or gritty. Patients have a sudden onset of severe pain, blurry vision, sensitivity to light.
Sounds pretty miserable.
It is. And if it's endogenous, meaning the infection started somewhere else in the body, you'll see signs of a systemic infection too.
So you have to look at the whole patient, not just the eye.
Exactly.
The AWARE book calls endophthalmitis an ocular emergency. They say you need to treat it quickly to prevent vision loss.
It's a race against time, absolutely.
Wow. So how do you even diagnose endophthalmitis? What are the key steps?
Microscopy and culture of an aspirate of the aqueous or vitreous humor.
Yeah.
Essential.
Okay, so getting a sample directly from the eye.
Exactly. We need to identify the culprit and see what antibiotics it's susceptible to. And if we think it's endogenous, we need blood cultures too.
Makes sense. You're not just treating the eye, you're looking for the root of the problem. So once you've identified the bacteria, how do you treat endophthalmitis? What does the AWARE book recommend?
Two-pronged approach. Got to tackle the infection in the eye directly and address any underlying systemic infection too. Intravitreal injections of antibiotics, that's the cornerstone. For exogenous cases, vancomycin and ceftazidime, and for endogenous cases, you add ceftriaxone and vancomycin systemically.
Whoa, injecting antibiotics directly into the eye, that's intense.
It is intense, but it's necessary with this condition. You have to be aggressive to try and save the vision. There are two main ways to do it: tap and inject and vitrectomy.
Okay, break those down for us. What's tap and inject?
Tap and inject is when we take a sample of vitreous humor for culture, then we inject the antibiotics right then and there.
Got it. And what about vitrectomy?
Vitrectomy is a surgery. We remove some of the inflamed vitreous humor, and during the procedure, we inject the antibiotics.
So a more invasive approach. The AWARE book mentions there's some debate about whether you need systemic antibiotics for endophthalmitis on top of those intravitreal injections. What are your thoughts on that?
It's complicated. Intravitreal antibiotics are the main treatment, but systemic antibiotics might help too, especially if the infection started somewhere else in the body. It really depends on the situation, the specific bacteria, how fast you can get the patient to a specialist.
So, no easy answers there. But having those AWARE guidelines helps with those tough decisions.
Absolutely. Having those guidelines is crucial.
Okay, so we've covered how to diagnose and treat endophthalmitis, but how does this infection even happen? What causes it?
Well, just like conjunctivitis, it can be exogenous or endogenous.
Okay, so remind us again, what's the difference?
Exogenous is from outside the body, often from penetrating eye trauma or eye surgery, or complications from keratitis.
So something breaks through the eye's defenses and lets bacteria in.
Yeah, you got it.
And what about endogenous cases?
Those usually come from bacteria or fungi in the bloodstream, from an infection somewhere else in the body, like endocarditis. It's a reminder that infections don't always stay put.
Everything's connected. And speaking of connections, let's talk about epidemiology. Endophthalmitis isn't as common as conjunctivitis, but are there certain people who are more at risk?
The book says that exogenous cases are most common, the ones that come from trauma, surgery, or keratitis.
Okay, so those are the main culprits. What about endogenous endophthalmitis?
Those cases are less common, and they usually happen in people who already have an infection somewhere else in their body, especially infections that spread to the bloodstream.
Got it. And it's important to remember that endophthalmitis specifically refers to bacterial or fungal infections. Viral and parasitic infections in the eye are called uveitis. We'll talk more about those later. But for now, let's stick with endophthalmitis. What are the most common bacteria that cause this infection?
The AWARE book breaks it down by exogenous and endogenous cases, and they list bacterial and fungal pathogens for each. Coagulase negative Staphylococci, those are the most common ones overall. They're often part of our normal skin flora, but they can cause problems if they get into the wrong place.
So they're kind of like opportunistic invaders.
Yeah, exactly. And for exogenous cases, we also see Staphylococcus aureus, Streptococcus species, and Bacillus cereus pretty often. And on the fungal side, Fusarium and Aspergillus species are common, especially after eye trauma involving plants.
Makes sense. Plants carry all sorts of fungi. What about the endogenous cases? Are the bacterial culprits similar?
Yeah, the bacteria are similar, but the fungal culprit is usually Candida albicans, and it often comes from the bloodstream.
Interesting. So those are the usual suspects for endophthalmitis. Now let's move on to another common eye infection, keratitis. You probably see a lot of these cases in your lab.
Oh yeah, keratitis, an infection of the cornea. That's the clear outer layer of the eye that lets light in.
And the AWARE book describes the symptoms in detail. Pain, blurred vision, tearing, that feeling of having something stuck in your eye.
It's definitely not a pleasant experience, and just like endophthalmitis, it's considered an ocular emergency because it can lead to blindness if you don't treat it quickly.
So time is of the essence. How do you confirm the diagnosis? What are the key diagnostic steps?
You need to look at a sample under the microscope and try to grow the bacteria in culture. We usually get the sample by scraping a cornea or taking a small biopsy, and if the patient is immunocompromised, we might do a nucleic acid amplification test to look for herpes simplex virus. That can cause keratitis too.
So similar approach to endophthalmitis, but the sample comes from a different part of the eye. What about treatment? How do you tackle bacterial keratitis?
Topical antibiotics, those are the first line of defense. The AWARE book recommends afloxacin eye drops, and you have to give them frequently, especially at the beginning.
Frequent dosing. That sounds like a lot of eye drops.
It is a lot of eye drops, but it's important. You need to make sure the antibiotics actually get into the cornea to kill the bacteria. Drops are usually better than ointments because they penetrate better. But you might use an ointment at bedtime for comfort, and sometimes, if the infection is really bad or there's a risk of the cornea rupturing, you might give oral antibiotics too.
So tailoring the treatment to the specific situation.
Exactly. And the AWARE book also recommends cycloplegic eye drops, like cyclopentylet or atropine.
What are those for?
They help with the pain and light sensitivity, and they prevent the pupil from sticking to the lens. It's all about making the patient more comfortable and reducing the risk of long-term damage.
Makes sense. So we've talked about how to diagnose and treat bacterial keratitis. Now, how does this infection actually happen?
Keratitis can be caused by lots of different microbes. Bacteria, fungi, viruses, even parasites. And the risk factors really depend on what's causing it. Contact lens use, eye trauma, and immunosuppression are all common culprits.
Right. The book specifically mentions Pseudomonas and Acanthamoeba species being associated with contact lens use.
Oh, we see those a lot in the lab, especially in young people who aren't as careful with their contact lens hygiene as they should be.
That's a good reminder that even something as simple as wearing contact lenses can have serious consequences if you're not careful.
Absolutely.
Okay, so now let's talk about the epidemiology of keratitis. The AWARE book says there are over 2 million cases a year, and there's a big burden in South, Southeast, and East Asia. But are the trends the same all over the world?
Not really. The book talks about some interesting geographical variations. In high-income countries, contact lens use is the most common risk factor, and most cases are caused by bacteria or viruses. But in low- and middle-income countries, trauma is a more common cause, especially trauma from plants, and those cases are often fungal.
Wow, that's a big difference. I guess that makes sense when you think about differences in access to healthcare, hygiene practices, and the types of jobs people do in different parts of the world.
Exactly. Context is everything.
Right. The book also says that keratitis is rare in kids, but when it does happen, it can be hard to diagnose. Why is that?
Well, kids might not be able to tell you exactly what's wrong, and it can be hard to get a good sample for testing. So you have to rely more on your clinical judgment and what you see during the exam.
So it's a different kind of challenge. Okay, before we move on to the specific microbes that cause keratitis, let's talk about another condition that can sometimes be confused with a more serious eye infection. Periorbital cellulitis. It's also called preseptal cellulitis.
Okay, periorbital cellulitis. That's an infection of the tissues around the eye, but it doesn't go beyond the orbital septum. It's more superficial.
So it's like a less serious version of orbital cellulitis.
Yeah, you could say that. It's usually a mild condition, and it's more common in kids.
Okay, so how do you tell the difference between periorbital cellulitis and the more serious orbital cellulitis?
Periorbital cellulitis usually causes swelling, redness, warmth, and tenderness of the eyelid, just on one side.
Sounds painful.
It can be. And the patient might have a fever, but their vision is usually normal. That's a key difference from orbital cellulitis, where you often see problems with eye movement, the eye might bulge out, and vision can be affected.
So those clinical signs are really important for making the diagnosis?
Definitely.
The AWARE book says that you don't usually need lab tests to diagnose periorbital cellulitis. Is that your experience too?
Yeah, most of the time, the clinical presentation is enough to make the diagnosis. It's hard to get a good culture, and blood cultures are usually negative.
But the book does say that sometimes a CT scan might be helpful.
Right. If the diagnosis isn't clear or if you're worried about complications, a CT scan can help you see if the infection has spread beyond the eyelid.
So it's a tool to have in your back pocket. Now let's talk about treatment. What does the AWARE book recommend for periorbital cellulitis?
Systemic antibiotics, usually given empirically.
Empirically, meaning you don't wait for the culture results.
Exactly. You start with an antibiotic that covers the most likely bacteria based on the clinical presentation, and then adjust the treatment if needed based on the culture results.
Makes sense. But with antibiotic resistance being such a big concern, how do you choose the right antibiotic?
It's a challenge, for sure. You have to consider the local patterns of antibiotic resistance. The AWARE book gives recommendations based on that, and you have to think about the individual patient. Have they taken antibiotics recently? Are they at risk for MRSA?
This is a personalized approach.
Absolutely.
The book recommends amoxicillin clavulanic acid, cephalexin, and cloxacillin for adults. But it says that amoxicillin clavulanic acid, or cephalexin, are often preferred over cloxacillin. Why is that?
Those two antibiotics cover a broader range of bacteria. They're effective against both gram-positive and gram-negative bacteria. And that's important because periorbital cellulitis can be caused by a variety of bugs, including some gram-negative ones.
So you're casting a wider net just in case.
Exactly. And for kids, the book gives specific dosage adjustments based on their age and weight.
Kids are always a bit trickier to dose, aren't they?
They are. You have to be careful because their bodies handle drugs differently than adults do.
Right. So the AWARE book says that most cases of periorbital cellulitis can be treated with oral antibiotics. But are there times when you might need to give intravenous antibiotics?
Yes, definitely. If the infection is severe, or if the patient is very young or can't take pills, we might need to give intravenous antibiotics to get the infection under control quickly.
And the book has guidelines for those more severe cases too.
Great. So we talked about how to diagnose and treat periorbital cellulitis. But how does this infection actually develop?
Most of the time, it starts with an infection somewhere nearby, like in the eyelid, the tear duct, the sinuses, or even the teeth.
So it's like a spillover effect.
Exactly. The bacteria from the initial infection spread to the tissues around the eye.
Makes sense. And the book also says that bites or trauma to the eyelid can cause periorbital cellulitis too.
Right. Anything that breaks the skin barrier can give bacteria a way in. Okay, now let's zoom out and talk about epidemiology again. We know that periorbital cellulitis is more common in kids, but are there any other trends to be aware of?
Well, the book points out that it's much more common than orbital cellulitis, which is good news. And most cases are exogenous, meaning they come from outside the body.
Okay, so those adjacent infections, bites, and trauma that we talked about are the main culprits.
Right.
Now, who are the microbial suspects behind periorbital cellulitis? Who are the usual culprits?
Staphylococcus aureus is number one, and that includes MRSA. Other common bacteria include Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis.
So a lot of the usual suspects we see in respiratory infections too.
Yep. And the book reminds us that if there's a bite involved or if there's any tissue death, we need to think about anaerobic bacteria.
Right, because those bacteria thrive in environments without oxygen.
Exactly. And let's not forget about viruses. If the patient has a rash with blisters, it could be herpes simplex virus or varicella zoster virus.
Those viruses can cause all sorts of problems.
They sure can.
Okay, we've covered a lot of ground with periorbital cellulitis. Now let's touch on a few other eye infections that the AWARE book mentions. orbital cellulitis, blepharitis, and infectious uveitis. Let's start with orbital cellulitis. It's much more serious than periorbital cellulitis, right?
It's definitely more serious. Orbital cellulitis involves the tissues behind the orbital septum. That's the tough membrane that separates the eyelid from the deeper structures of the eye socket. It's a deeper infection, and it can spread quickly.
So why is it so dangerous?
Well, because it can affect the muscles that move the eye, the optic nerve, and even the blood vessels that supply the eye and brain. If it's not treated quickly, it can lead to vision loss, blood clots in the sinuses, and even infection in the brain.
Yikes, that's scary.
It is scary. It's a serious condition that needs to be treated in the hospital.
And the bacteria that cause orbital cellulitis are different from those that cause periorbital cellulitis, right?
Well, there's some overlap. Staphylococcus aureus and Streptococcus species are common in both. But orbital cellulitis often involves a wider range of bacteria.
So it's a more diverse group of microbes.
Yeah, you could say that.
The AWARE book says that Haemophilus influenza used to be a common cause in kids, but it's less common now because of the Hib vaccine.
That's a great example of how vaccines can really make a difference.
Absolutely. And the book also says that Pseudomonas aeruginosa and Escherichia coli often cause orbital cellulitis after trauma to the eye.
Right. Those bacteria are opportunistic pathogens. They're always looking for a chance to cause trouble.
And if someone has a dental infection, especially an abscess, that can also spread to the eye socket and cause orbital cellulitis.
Yeah, and those cases are often polymicrobial, meaning they involve multiple types of bacteria, including anaerobes.
So it's important to consider the potential source of the infection when you're evaluating someone with orbital cellulitis.
Definitely. Every clue counts.
Now let's move on to blepharitis. It's an infection of the eyelid margins, right?
That's right. It can affect the front part of the eyelid, where the eyelashes are, or the back part, where the oil glands are.
And you said earlier that it's often caused by Staphylococcus species and Demodex mites, but it's not always a true infection.
Right. The book points out that most cases of blepharitis are actually chronic and caused by problems with the oil glands, not infection. But infection can play a role, especially in the type of blepharitis that affects the oil glands.
So it's more of an inflammatory condition in many cases.
Exactly. But chronic infection can contribute to the problem.
And the book lists Staphylococcus aureus, Coagulus negative staphylococcus, Demodex folliculorum, and Demodex brevis as common culprits. But it also says that these microbes can be found in people without blepharitis.
Yeah, it's not totally clear what role they play in causing the condition. It's probably a combination of factors.
Okay, so what does blepharitis look like? What are the symptoms?
The eyelids are usually red, swollen, and itchy, and they might have crusts at the base of the eyelashes. It usually affects both eyes, and the symptoms are often worse in the morning.
And you mentioned earlier that there's a special type of blepharitis associated with Demodex mites that has a characteristic appearance.
Right, you see these cylindrical dandruff flakes or sleeves on the eyelashes. It's a subtle finding, but it can be helpful in making the diagnosis.
So it's all about those little details. And while blepharitis is more common in adults, kids can get it too.
They can, and in kids, the infection often affects the conjunctiva and cornea more than it does in adults.
Interesting. So how do you diagnose blepharitis? Does the AWARE book recommend any specific tests?
Nope, usually you don't need any lab tests. The clinical presentation is usually enough. And you might be surprised to hear that antibiotics aren't always necessary either.
Really? So how do you treat it if you don't use antibiotics?
Good eyelid hygiene is key. Warm compresses, gentle massage of the eyelids, and regular cleaning can really help.
So it's more about managing the symptoms and keeping things clean than trying to kill a specific bug.
Exactly.
Okay, last but not least, let's talk about infectious uveitis. The AWARE book defines it as an infection of the uvea, which is made up of the iris, the ciliary body, and the choroid.
It's basically an inflammation of the middle layer of the eye, and it can be caused by a lot of different things.
So unlike some of the other eye infections we've talked about, infectious uveitis is often a sign of another infection somewhere else in the body.
Exactly. The eye is connected to the rest of the body, and infections can spread.
Makes sense. Now, the AWARE book lists a whole bunch of bacteria, parasites, and viruses that can cause infectious uveitis. But before we get into the specifics, let's talk about epidemiology. Are there certain people who are more likely to get infectious uveitis?
It really depends on what's causing it. For example, cytomegalovirus, which is a common cause of infectious uveitis, is more common in people with weakened immune systems.
So the patient's overall health and medical history are important clues.
Definitely.
Okay, so what does infectious uveitis look like? What are the symptoms?
It depends on which part of the uvea is affected. But generally, people have pain, redness, and blurred vision.
Sounds pretty serious.
It can be. And the book says it's important to refer patients with suspected infectious uveitis to an ophthalmologist right away because it can damage the eye and cause vision loss. Absolutely. Early diagnosis and treatment are essential.
Well, we've covered a lot of ground today, exploring a range of bacterial eye infections through the lens of the World Health Organization's AWARE Antibiotic Book.
It's been a fascinating journey, from the common cold of the eye, conjunctivitis, to the more sinister endophthalmitis.
And we've delved into the nuances of periorbital cellulitis, blepharitis, and infectious uveitis, highlighting the importance of careful diagnosis and appropriate treatment. But before we move on, I thought it would be fun to put your knowledge to the test with a few exam-style questions, just like those you might encounter in your microbiology practice. Ready to play?
Hit me with your best shot. I'm ready. Okay, let's hear them.
First question, straight from the world of conjunctivitis, and the AWARE book, of course. Which of these is the most common cause of conjunctivitis? Is it A, bacteria, B, viruses, C, fungi, or D, parasites?
Most common cause. That would be B, viruses. Viruses are definitely the most common culprit for conjunctivitis.
Nailed it. Okay, let's step it up a notch. We're in the newborn nursery now. A newborn has purulent eye discharge. It started a few days after birth. What's the most likely cause? A, chlamydia trachomatis, B, Neisseria gonorrhoeae, C, herpes simplex virus, or D, adenovirus.
Oh, neonatal conjunctivitis. Got to think about the timing here. Purulent discharge within the first few days. Got to be B, Neisseria gonorrhoeae. That early onset and the purulent discharge are classic signs of gonococcal ophthalmia neonatorum.
You're on fire.
Yeah.
And that's why that prophylactic treatment is so important. Erythromycin or tetracycline ointment can really prevent some serious complications. Okay, next question. This is about keratitis. According to the AWARE book, what's the primary treatment for bacterial keratitis? A, oral antibiotics, B, topical steroids, C, topical antibiotics, or D, surgery?
Primary treatment for bacterial keratitis. Got to go with C, topical antibiotics. You want to hit those bacteria directly on the cornea.
Exactly. Right on target. And remember, the AWARE book emphasizes frequent dosing, especially in the beginning. Okay, next question. This one tests your clinical judgment. Which of these features helps you tell the difference between orbital cellulitis and periorbital cellulitis? A, red and swollen eyelid, B, restricted eye movements, C, pain when you touch the eyelid, or D, fever?
Distinguishing those two. Well, they can both have a red, swollen eyelid, and pain when you touch it, and fever. But B, restricted eye movements. That's a big red flag for orbital cellulitis. It means the infection has spread deeper.
Right again, you're 5 for 5. Last question. You're called in to see a patient with suspected endophthalmitis. What's the most important first step? A, start oral antibiotics. B, apply topical antibiotic ointment. C, give a cycloplegic agent. Or D, refer to an ophthalmologist.
Endophthalmitis. Oh, that's an emergency. Got to act fast to protect the vision. Definitely D, refer to an ophthalmologist immediately. They need to see this patient ASAP.
Couldn't have said it better myself. You aced it. Clearly, you know your eye infections and the AWARE guidelines like the back of your hand.
Well, I do spend a lot of time with these little microbes.
And it shows. But those exam questions, they're just a tiny glimpse into the real-world challenges of managing eye infections. What are some of the biggest hurdles you face in your work, especially in the context of these AWARE guidelines?
You know, the guidelines are a great starting point. But one of the biggest challenges we face is antibiotic resistance. It's constantly evolving. What worked last year might not work this year.
It's like a moving target. So how do we stay ahead of the game?
Well, in the lab, we have to keep tracking those resistance patterns, and we need to communicate those findings to the clinicians. And in the clinic, it's all about using antibiotics wisely, choosing the right antibiotic for the right bug, and making sure patients finish their full course of treatment.
So it's a team effort. Clinicians, microbiologists, pharmacists, and patients all working together.
Exactly. We're all on the same team, and we need to work together to protect these antibiotics.
Absolutely. Now let's circle back to our discussion of eye infections. We talked about periorbital cellulitis, but the AWARE book also covers orbital cellulitis in more detail. Can you remind us why this condition is so much more serious?
Orbital cellulitis, it's all about where the infection is. It's behind the orbital septum. That's a tough membrane that separates the eyelid from the eye socket. So the infection is deeper, and it has the potential to spread and cause some serious problems.
Okay, so it's in a more dangerous location. But what makes it so dangerous? What kind of problems can it cause?
Well, it can affect the muscles that control how the eye moves. and the optic nerve, and even the blood vessels that go to the eye and the brain. You could have vision loss, blood clots, even the infection could spread to the brain.
That's serious stuff. No wonder the AWARE book says you need to hospitalize these patients and get specialists involved.
Absolutely. This is not something to mess around with.
And the bacteria that cause orbital cellulitis are different from those that cause periorbital cellulitis, right?
There's some overlap, but orbital cellulitis can be caused by a wider range of bacteria.
So it's a more diverse group of microbes.
Yeah. Staphylococcus aureus and Streptococcus species are common, but you also see Haemophilus influenza in kids, although that's less common now because of the Hib vaccine. And if there's been trauma to the eye, you often see Pseudomonas aeruginosa and Escherichia coli.
And what about dental infections? Can those cause orbital cellulitis?
Oh, yeah, definitely. Especially abscesses. Those can spread to the eye socket, and those infections are often polymicrobial. Lots of different bacteria involved.
So it's like a mixed bag of microbes.
Exactly. And anaerobes are often involved, too.
Makes sense. So when you're evaluating someone with orbital cellulitis, you have to consider all those potential sources of infection.
You got it.
And the AWARE book gives specific recommendations for antibiotic treatment. But I imagine the approach is much more aggressive than for periorbital cellulitis.
Much more aggressive. Intravenous antibiotics are usually needed, and often for a longer period of time.
And the choice of antibiotics depends on the bacteria, the local resistance patterns, and the patient's overall health.
Exactly. It's a complex decision.
Now let's switch gears again and talk about blepharitis. Remember, it's that inflammation of the eyelid margins. The book says it's often caused by Staphylococcus and Demodex mites, but a lot of times it's not really an infection, right?
Right. It's often more of a chronic inflammatory condition. The oil glands in the eyelids aren't working properly, but infection can make it worse.
Okay, so it's like a delicate balance that's been disrupted.
Exactly. And while the AWARE book doesn't go into detail about how to manage blepharitis, it does emphasize good eyelid hygiene.
So what does that involve? What kind of advice would you give to a patient with blepharitis?
Warm compresses are good. They help soften any crusting. And gentle massage of the eyelids can help unblock those oil glands. And keeping the eyelids clean is important. You can use a mild soap or a special eyelid cleanser.
So it's about keeping things clean and under control. Okay, last but not least, let's revisit infectious uveitis. Remember, it's that infection of the uvea, the middle layer of the eye, and it can be caused by a whole host of microbes. The AWARE book doesn't really go into the treatment, but it does stress the importance of sending these patients to an ophthalmologist.
Yeah, definitely. Infectious uveitis can damage the eye and cause vision loss, so it's important to get specialized care.
And why is an ophthalmologist the best person to manage these cases?
Because they have the expertise to figure out what's causing the uveitis, and they can determine how bad the inflammation is, and they know the best way to treat it.
So it's another example where you need a team approach.
Absolutely. It takes a village.
Now, the AWARE book lists a lot of potential culprits for infectious uveitis, bacteria, parasites, viruses. It's quite a lineup.
It is, and knowing a little bit about each of those microbes can help you connect the dots between the eye infection and what's going on in the rest of the body.
So it's like having a microbial roadmap.
Yep.
For example, the book mentions Bartonella henselae. That's the bacteria that causes cat scratch disease.
Yep. Sometimes that can cause uveitis too.
And then there's Mycobacterium tuberculosis. That's the bacteria that causes TB.
Right. TB can affect the eye too. Usually it spreads from the lungs or somewhere else through the bloodstream.
And what about syphilis? Can that cause uveitis too?
It can. It's usually a late manifestation of syphilis. If the infection isn't treated, it can spread to the eye.
So many potential causes.
Lots of possibilities. And on the parasitic side, Toxoplasma gondii is a common culprit for infectious uveitis. That's the parasite that you can get from undercooked meat or cat feces.
So another reminder to wash your hands thoroughly after handling raw meat or cleaning the litter box.
Exactly. And we can't forget about the viruses. Cytomegalovirus, herpes simplex virus, varicella zoster virus, they can all reactivate and cause uveitis.
Those viruses are sneaky, always lurking in the shadows. Well, we've covered a lot of ground today, exploring orbital cellulitis, blepharitis, and infectious uveitis. We talked about the causes, the symptoms, the importance of diagnosis, and the need for specialized care.
It's been a great review.
And we've highlighted the role of the AWARE book in guiding treatment decisions and promoting responsible antibiotic use.
Definitely an important resource.
But before we wrap up this episode, I have one more thought-provoking question for you. The AWARE book really emphasizes responsible antibiotic use. So I'm curious, what role does antimicrobial stewardship play in managing bacterial eye infections? It seems like a real balancing act.
Yeah.
You want to treat the infection effectively, but you also don't want to contribute to antibiotic resistance.
Yeah, it's a tough one. Eye infections can be really serious. They can even threaten your vision, so you need to treat them aggressively. But at the same time, we have to be mindful of antibiotic resistance. It's a huge problem.
So how do we find that balance? What are some of the key things to keep in mind when we're thinking about antimicrobial stewardship for eye infections?
Well, first and foremost, you got to make sure it's actually a bacterial infection. You don't want to be throwing antibiotics at a virus or an allergy.
Right, so accurate diagnosis is key.
Absolutely. Take a good history, do a thorough exam, and use the right diagnostic tests.
Back to the basics.
Always a good place to start. And once you're sure it's a bacterial infection, you got to choose the right antibiotic.
And how do you do that?
You have to think about the most likely bacteria causing the infection. And what are the local resistance patterns? And what's going on with the patient? Do they have any allergies? Have they taken antibiotics recently?
A lot to consider.
It is, but the AWARE book provides a really helpful framework for making those decisions. It emphasizes choosing narrow-spectrum antibiotics whenever possible.
Narrow spectrum.
Yeah, you want to target the specific bacteria that are causing the problem without killing off all the good bacteria. That can lead to all sorts of other issues.
Like resistance and secondary infections.
Exactly.
So it's about being precise with our antibiotic choices.
That's a great way to put it. And once you've picked the right antibiotic, you have to make sure the patient gets the right dose for the right amount of time.
Right, too little, and the infection might not go away completely, and that can lead to resistance. But too much can cause side effects and contribute to the overall problem of antibiotic overuse.
Yep, it's a balancing act. And the AWARE book has those recommendations for dosage and duration. They take into account the patient's age, weight, and how bad the infection is.
So the guidelines are there to help us make those decisions. But we can't forget about the patient's role in all of this. Patient education is so important.
Absolutely. We need to help patients understand why it's important to finish all their antibiotics, even if they start feeling better before they're done.
And we need to make sure they understand that antibiotics aren't a magic bullet for everything.
Yeah, they only work against bacteria, and they're not always the answer.
So it's a team effort. We all have a part to play.
We do.
Now, before we wrap up this episode, I want to touch on something you mentioned earlier. You talked about the importance of surveillance and research in the fight against antibiotic resistance. What are some of the things that are happening right now that give you hope for the future?
Oh, there's a lot of really cool research going on. Scientists are looking for new antibiotics and exploring alternative therapies like phage therapy.
Phage therapy. That sounds pretty futuristic.
It does, but it's real. Phages are these viruses that can kill bacteria, and we can use them to fight infections.
So it's like using one microbe to fight another microbe.
Exactly. And they're very specific. They target the bad bacteria without harming the good bacteria.
That's amazing. What about those strategies to boost our own immune systems?
Yeah, our immune systems are pretty incredible. They do a lot to protect us from infection. And researchers are looking for ways to make them even stronger.
So we can fight off infections better on our own.
Exactly.
It's really an exciting time to be in this field. So much potential for discovery and innovation.
I agree. And I have no doubt that you, as a medical microbiologist, will play a key role in those discoveries.
Well, I'm definitely inspired. Thank you so much for joining us today. This has been a fantastic deep dive into the world of bacterial eye infections.
It's been my pleasure. Keep up the great work.
And to all our listeners, thank you for joining us on this journey into the microscopic world of eye infections. We hope you learned something new today. Remember, stay curious, keep learning, and never underestimate the power of those tiny microbes. Until next time, stay well.